Welcome to the AOT Pod, an all-new FRCS-themed podcast, tackling key themes, challenging topics, and insightful intellect within otolaryngology. Hosted by Livy Kenyon and myself, Kala Kumarasan, with the support from the ENT UK Foundation and AOT. Your guide to passing the ENT FRCS starts here as we take you around the country speaking to some of the best and brightest minds our specialty has to offer. So without further ado, let's begin.
Thank you, Livy and Carla. My name is Meng. I'm one of the ENT ST5 registrars in the North Thames Deanery. Today's podcast team is head and neck team, deep neck space infections. And I'm very pleased and privileged to be joined by Ms. Liu, our head and neck consultant at Northwick Park Hospital, who is also the chair of our head and neck MDT. So Ms. Liu, thank you for joining us today.
Thank you for inviting me. It's a real pleasure.
So before we dive into the clinical material of the podcast, could you share a few words on how would you prepare for your FRCS exam and any advice you would give upcoming candidates?
FRCS for me was a very long time ago. So part one is knowledge-based. Lots of MCQs. I think the most useful things I found is going to courses and doing past questions. Make sure before the exam you do one sit-through of a mock exam where you do a large volume of MCQs in the exam format, because it really helps you to get your timings right. You might find that you don't have enough time to answer all the questions otherwise. Second part, the OSCE part. This part really, really important to get some friends, get into groups and practice. For the second part, you should have all the knowledge you need, but you need to present it in an organized way that your examiners will be able to pick up nice and easily, and they'll be able to score you on the score sheet without having to work too hard to pick up the information. Finally, make sure you get a break between part one and part two. It's a long time to be studying continuously. I think a couple of months break between part one and part two is going to do you a lot of good. You won't forget everything, and it will just put you in a better place.
I think those are very helpful tips. Thank you very much for sharing them. Was it very difficult for you to juggle your work commitments, surgical training with exam preparation at the time?
Well, yes, I do remember a time period when I seemed to be attending courses every single weekend for FRCS, which I can imagine if you have a family as well, that's going to be much harder work. But like I said, take a break every now and then. Make sure the volume of work you get through is something that you can cope with. Because if you overwork yourself, you'll become less efficient.
Okay, excellent tips. So let's come to the actual podcast itself. I'll start off with a clinical scenario. So we have a 35-year-old man who presents to the A&E with severe sore throat, odonophagia, trismus, fever, and then left-sided neck swelling. Flexible nasal endoscopy revealed bulging of the lateral pharyngeal wall. So we are suspecting a deep neck space infection here. Before we jump into the clinical features, can you talk us through what relevant anatomy you're thinking of in this case?
In terms of the deep neck space infections that we encounter in ENT, it mostly tends to be paratonsillar abscesses being the most common, or parapharyngeal abscess, retropharyngeal abscess also common in children, and general lymphadenitis, which can give you a necrotic abscess down levels anywhere between 2 to 4 and 5. So you need to be really familiar with the anatomy of firstly the parapharyngeal space, levels 2 to 4 in the neck, and the retropharyngeal space. So to start with the parapharyngeal space, quite hard to visualize the parapharyngeal space because it's not something that's visible on the outside of the neck. It's not something that you encounter routinely in your daily practice. So what it is it's a triangular space sitting behind the tonsil, so deep to the tonsil and the superior constrictor, between the base of skull and down to the hyoid bone. So essentially, imagine them as two little triangles going down from the side of your throat down to the hyoid bone. It's usually the anterior space adjacent to the tonsils that becomes involved in deep neck space infections, the prestyloid space. The post-styloid space contains the carotid vessels and the nerve sheath bundle, which generally isn't really affected in infections. To manage a parapharyngeal space abscess, well, we can talk about that in greater detail a little bit later on. We can talk about, do you approach it intraorally or do you approach it externally? These are very important considerations for a surgeon in management of these neck space abscesses. The retropharyngeal space only contains significant lymph nodes in children. So this is a space that's actually subdivided into several different spaces So the retropharyngeal space and the prevertebral space, and these are slightly different spaces in how deep they extend down into the neck and the mediastinum. Generally, this only gets infected in children because they still have lymph nodes which have not regressed at this stage, and it can also be involved in foreign bodies that penetrate the retropharyngeal space, such as fish bones. Finally, a sort of deep neck space abscesses we encounter as ENT tend to be the submandibular and submental spaces, which can either be styloadenitis or dental infections. Dental infection being much more common than styloadenitis or salivary gland abscesses. It's important to note that fascial planes are not absolute barriers to anatomical spread. Sometimes you will find complex neck space infections that cross multiple boundaries, and really you need to look at the CT scan very closely, make a judgment as to which spaces are affected and how you're going to approach managing these patients. So, yep.
So earlier on you mentioned fishbone as one of the common cause of retropharyngeal infections. In this group of patients with deep neck space infections, can you think of any other common causes?
So we've got fishbone, tonsillitis, salivary gland infections, dental infections. I think one thing I would like to mention here is necrotizing fasciitis, which is a non-abscess forming deep space infection. And this can happen from relatively minor trauma. And sometimes there is no precipitating history of trauma at all, and there may not be significant swelling, and the clinical findings are generally out of proportion with how sick the patient is. So you expect to face a very unwell septic patient, sometimes with minor skin change. So in deep neck space abscesses, you don't always see skin change because it's compartmentalized by the deep investing fascia, which goes all the way around the neck like a scarf. Whereas necrotizing fasciitis spreads along the superficial and deep fascial planes. So you generally will see some skin change. It might be pinkish, it might be purple. Purple is definitely a bad sign. That means you might have necrosis. And if you feel the neck, there might be crepitus. Necrotizing fasciitis is something that's been on the rise in recent years in the UK. We've had a number of relatively unexpected cases at London Northwest Healthcare. And it's really important to catch these cases early. These will require very aggressive medical and surgical management, often multiple debridements.
Sounds like a horrific presentation. Then.
It is. It's even more terrible if you leave it too long and miss it, unfortunately.
So in line with the clinical scenario earlier, what are some of the common clinical symptoms that these patients tend to present with in adults and in children?
So often we see deep neck space infections as an extension of tonsillitis. So tonsillitis, as you know, presents with bilaterally enlarged tonsils. The soft palate is generally not enlarged. You may get erythema, and then you get swelling. So swelling indicates cellulitis or pus. So where is that swelling? The swelling could be intraoral, around the tonsil itself, in which case it's a paratonsillar or a parapharyngeal abscess. For a parapharyngeal abscess, you would generally expect extension of swelling from the lateral pharyngeal wall down to the larynx. And if the abscess is really very extensive, you will start to see swelling on the neck. Swelling on the neck is actually quite an uncommon and late sign of parapharyngeal abscess, but it can happen. More often, you will get patients saying that their neck is very painful, that they have trismus, which means there is pus along the masseter muscles causing inflammation. Or if you turn their head, they say that's really, really painful, out of proportion to your examination findings. So they might have voice change, they might have drooling, they might have hot potato voice, so they might be spitting their saliva into a bowl, and also systemic symptoms, fevers, circulatory collapse, all of those things. That's not very good. Stridor tends to be a very late presentation of parapharyngeal abscess. That's really, you have a very critical patient. Mostly they develop swallow symptoms, pain, and neck movement restriction first.
Would you say neurological deficits are common symptoms for this group of patients?
I would say it's extremely uncommon. I would say that which cranial nerve were you thinking of?
So, for example, if the carotid sheath was
vagus. Yeah, the carotid sheath itself is extremely resistant to infection. So, if you do have cranial nerve palsy, it's going to be as a result of Lemierre's syndrome. Right. So that means septic embolization and clotting off of the IJV. But even then, it's quite rare to see cranial nerve palsy.
Okay. I see. So we will examine these patients with flexible endoscope. We will see pharyngeal bulge. We could see possibly airway narrowing. Are there any other signs that you will see on examination?
You might see epiglottic swelling. You might palpate swelling in the neck. Other than that, you might see the floor of mouth is swollen. But definitely look for any sort of swelling that's unexpected. So pharyngeal or retropharyngeal are the most common places.
Okay, I see. So when these patients present to us in the emergency setting, what are some of the red flags that some alarm bells for us that we need to rush to manage patients in theatre?
Well, the eyeballing the patient is extremely important. Any signs of airway compromise or significant sepsis, those will be my red flag signs, like stridor, not being able to handle secretion. So I think the top two that I would really worry about is any evidence of stridor. So airway compromise is significant enough to cause a noise when they breathe, and significant sepsis, so hypotension, tachycardia that really needs treatment straight away. Things like drooling is actually quite common, and as you know, also happens in significant tonsillitis. That wouldn't worry me so much, but it would say to me that the patient needs inpatient management, because they wouldn't be able to tolerate oral intake if you were to send them home. The signs of mediastinitis is very, very uncommon, and they probably will not be able to describe things like chest pain or shortness of breath to you, but you will find that in the textbooks as well. So my top ones will be airway compromise and septic shock. Those will be the commonness that you're looking for. And for those, I would certainly consider anesthetic input and escalation to IT.
So what investigations would you recommend as first line for these patients?
So after your history and examination, you think, okay, this patient needs to come in, needs to be managed. So start with your routine blood tests, FBC, use knees, CRP, blood cultures, imaging. So the first line would be a CT neck and chest with contrast. You can do an MRI as well if you suspect vascular spread or intracranial spread. But a lot of places will have difficulty accessing MRI out of hours, and the CT neck will give you all the information you need to manage the patient in the first instance. You can either aspirate the pus at the bedside, either from a paratonsillar abscess and send it off for microbiology and culture, or you can arrange an ultrasound and aspiration.
Okay. So say if you manage to luckily aspirate some pus for culture, what sort of bugs tend to grow from this sort of culture for these patients?
These all tend to be sort of polymicrobial infections, anaerobic predominant. So some of the particularly nasty bugs is Fusobacterium and Strep milleri. These tend to cause very significant extensive abscess formation, often require multiple washouts. Things like staph and viridans, these can spread to the blood and cause infective endocarditis as well. Other things tend to be quite rare, but mostly oral organisms. Think about oral cavity organisms, think about dental infections. This is where the bugs come from. So you're essentially looking at oral flora.
So after the first line investigations are done, what are your main management principles for these patients?
So for your exams and for your everyday practice, stay safe. Okay, so assess the patient in a systematic manner, A, B, C, D, E. So you know this is a condition that can potentially compromise the airway. So assess the airway first. Is there stridor? Is there significant swelling on your flexible nasendoscopy? If you are worried and if you think this might progress, then contact anesthetics early. Remember to assess mouth opening as well. We're often not very good at doing that because we do our scopes through the nose. But if you have a significant trismus, that can really present a significant challenge to intubation and management by anaesthetic. So that's the first thing that they would want to know. If people are sick, remember to involve ICU. Remember to look at your local microbiology guideline. What's the first line antibiotics you should start? What's the second line antibiotics you should start? Is there a dental cause? Odontogenic infections cause a heck of a lot of deep and neck space abscesses. So they cause Ludwig's angina. They cause submandibular abscesses. The upper teeth can cause temporal abscesses. So all of these things you need to consider, because as an ENT surgeon, if you have a neck abscess that arises from a dental cause, you won't be able to manage that fully without involving OMFS. is there spread to inferiorly to the mediastinum? If there is mediastinal extension, you may need to involve cardiothoracics when you come to your surgical management. So think about all of these people that you would need to involve early. But if you're worried at all, the first people you should call are anesthetic and ICU. That's certainly the most important. Breathing is rarely affected in deep neck space abscesses. So we move on to C, circulation. Remember to establish IV access, wide bore cannulae, both antecubital foci, give IV fluids fast, give antibiotics as soon as you're able. Make sure that you follow local microbiology guidelines with anaerobic cover. And once you've got the patient stabilized, you can start considering, does this need to go to surgery, or does this need to, is the patient stable enough for a 24-hour trial of IV antibiotics and dexamethasone? So that's how I would shoot in the first instance.
Okay. So we understand that airway obstruction can obviously be a huge red flag for this group of patients. So how would you formulate an airway plan together with anesthetics if the patient's airway is compromised?
So I would probably manage this in two ways. So you have a very skilled group of anesthetists with airway interest. So you kind of need to have an idea in your head of plan A and plan B and communicate that early to your colleagues. So if you have relatively young anesthetists who are not confident in doing things like fiber optic intubations, and the patient does have significant trismus and airway swelling, you need to think about accessing front of neck access early. You need to think about, if the patient's not that unwell, do we need to put in local anesthetic trachea? That is a procedure where you as a surgeon is full control. So that's what I would do if I were working in an unfamiliar environment with people whose level of skill I'm not certain of. You cannot be assured that the anaesthetist comes to help you in the middle of the night will be able to do either front of neck access or fiber optic intubation. And if you're not sure about it, it's best to ask them early, what do you think about local anesthetic trachea, or are you comfortable intubating this in other ways? So make sure you share your flexible nasal endoscopic findings with your anesthetic colleagues. They'll be very grateful and appreciate that. And if you have any worries or concerns, you're not just treating the patient in front of you at that moment in time. You need to think about 6 hours down the line, is this patient going to be better or worse? And if it is the patient is potentially going to get worse before they get better, where should you monitor them? Should they be in resus? Should they be in HDU? Where should they be monitored where they're not just stuck in the side room and people check on them once every 2 hours? So think about putting in your colleagues and making sure the patient is in an area of safety.
Okay. So in terms of potential complications from deep neck space infection, we have covered some of it already, including airway compromise, mediastinitis, and Lemierre syndrome. Are there any particular pointers from these complications that you would like to emphasize?
So these complications, like we discussed previously, are quite rare. You can see hundreds of deep neck space infections with only 1 or 2 having these complications. What I would say is that these complications generally arise from infections that have not been treated for a significant period of time. So it's rare for someone with a 2-day history of deep neck abscess to present with Lemierre syndrome. So it's quite important to reassess the patient at a later date, is what I would say. Is if there's, for example, you've had them on antibiotics for 48 hours, they're improving but not as fast as you would like them to, consider repeating your CT scan, consider repeating your blood tests, consider approaching everything as a fresh start, because some of these complications that are not visible on initial presentation may develop later if they haven't responded to treatment adequately, especially Lemierre's. Lemierre's is relatively common compared to the other cranial nerve palsies and septic emboli.
Okay, so if CT findings come back showing an abscess or the drainable collection, we certainly have to consider surgical drainage. So can you talk a bit more about how you approach surgical drainage techniques for deep neck space infections?
Okay, so the first thing I would actually say you've now done your CT scan at 24 hours post admission, or indeed on admission if you felt the patient was unwell. The first thing I would actually question is this abscess big enough to drain? Is it something that I'm going to find? Because radiologists will report any kind of deep neck space infection as potential abscess. You need to look at the images yourself. Where is the abscess? Is it in one compartment, or does it across multiple compartments? And does it actually contain enough pus for you to drain? So if something is mostly cellulitic and there's not much of a liquid component, then you're not going to be very successful in surgical drainage. You may as well leave that on antibiotics for a couple of days before trying to go in, for the abscess to mature and liquefy in the middle. Otherwise, it's always very unsatisfying to take a patient to theatre, possibly in the middle of the night, and only find cellulitis. So that's the first thing I would say. Review the images yourself, measure the liquid component of the abscess. I would say anything less than 1.5 to 2 centimeters is probably not worthwhile draining. Useful to treat that conservatively in the first instance. Second is consider how to drain this abscess. So intraoral drainage of abscess is generally less invasive, and people recover from it more quickly than external drainage. However, there will be circumstances where you do need to drain externally. So let's stick with the intraoral drainage first. So these are good for parapharyngeal abscesses arising from tonsils and retropharyngeal abscess. It's easy to get to these two spaces. So parapharyngeal abscess, you know how to approach this. Make a incision essentially around the circumference of the tonsil that you're interested in, and so essentially make a curvilinear incision across the soft palate and see if you can find the abscess. Sometimes you can't find the abscess, it's a bit too lateral, in which case I would recommend removing the tonsil first. So do a tonsillectomy, and at the bed of the tonsil you will see the constrictor muscles. So at that point you put in a blunt instrument straight into the constrictor muscles and open up on the other side, and you'll almost certainly find your paratonsillar or parapharyngeal abscess. For retropharyngeal abscess, you just simply find the most prominent or most bulging part of this abscess and incise it in a vertical incision about 2 to 3 centimeters. You don't want to make an incision all the way across a retropharyngeal abscess, because when they wake up and when they start to eat and drink, you don't want there to be such a big gap in the retropharyngeal space that food and drink starts to collect down it. Often you will find people who've had a retropharyngeal abscess incised might need an NG tube to tie them over a couple of days. So that addresses intraoral. Next are the external incisions. So the external incisions, we start from the top. Mental incisions is usually for Ludwig's angina, and because this is usually caused by a dental infection, Maxfacs tend to do it far more than we do. But essentially, you make incisions parallel to the sort of from the submental area towards the mandible, and you make multiple incisions. You might make 2, you might make 3, and you need to open up all of that submandibular mylohyoid space all the way sort of into the floor of mouth mucosa, really, and put in some big drains. And for draining a Ludwig's angina, you will also almost always need to put in a covering tracheostomy because it displaces the tongue backwards so much that they usually will have airway compromise. Mandibular abscess and sort of levels 2 to 4 neck abscesses, I simply approach these with skin crease incisions at the level that's required. I would use the same incision to drain a submandibular abscess as I would for an external approach to a parapharyngeal abscess. So a skin crease incision around 4 or 5 centimeters at the level of the hyoid bone, and once you get in there, you lift up the submandibular gland, you find the digastric, and you simply push through with a pair of blunt forceps, blunt mosquitoes, and you should get into that area. With complex abscesses, sometimes you might need to put in a mediastinal drain. It's fairly straightforward. You just go down, follow the trachea into the mediastinum, and put in a small drain facing downwards in that area.
Is it common to require both internal and external drainage?
Uncommon. I would say I normally do either one or the other because I'm worried about fistulation. It rarely happens, but I would generally choose one or the other. I would probably say if you've tried sort of intraoral drainage, it doesn't work, and then go for external. Normally, go for where the abscess is predominantly. So if it's predominantly underneath the sternocleidomastoid, then go for external. If it's predominantly under the oropharyngeal mucosa, then go for intraoral. It's rare for you to need to do both approaches at the same time, and I would probably try to avoid it. I would do one or the other and see which one works better.
Okay. It's all very comprehensive. I'm sure you have covered a lot of points about the neck space infections already. But when it comes to candidates answering questions in FRCS about this topic, do you have any further pointers?
I think for the purposes of FRCS, be safe. They want you to be able to answer things in a structured manner. And so I would say go through ABCDE first. Make sure you've mentioned you would stabilize the patient. And then you sort of want to get down to the nitty-gritty of what type of abscess it is, how you would manage it. Say, they will probably give you a scenario that points to one particular type of abscess, whether it's parapharyngeal, retropharyngeal. And so I would say first give a reasonable list of differentials. Once you've stabilized the patient, say, this is my list of differentials and this is why it is. And then go on to how you would investigate this patient with the investigations we've mentioned so far. And after that, go on to surgical techniques.
Very nice. Thank you, Ms. Liu. So to summarize the key points that we talked about, neck space infections can be rare, but they can be potentially fatal. And it's worthwhile remembering different fascial planes and that some of this could permit rapid spread to the mediastinum. The most common causes in adults are often odontogenic. In children, can be retropharyngeal or foreign bodies. We should approach this with an ABCD approach and always assess and protect the airway first. In terms of investigations, CT nav with contrast seems to be the gold standard imaging investigation, and IV antibiotics and surgical drainage are the cornerstones of management. Complications to watch out for include airway obstruction, mediastinitis, Lemire syndrome, etc. Any other key points that you would like to add to summarize?
I think that's very comprehensive. I think one thing I would actually add, which I don't think we've mentioned so far, is don't forget the radiologists. Sometimes they'll do a nicer ultrasound and drainage for you. Often doesn't work for a really big abscess, but for small abscesses and for children, that can be particularly helpful.
Okay, great. So thank you very much, Ms. Liu, for your time and expertise in this. This has been an excellent and practical summary on deep neck space infections, which is a life-threatening but often under-revised topic in the FRCS curriculum. And thank you to everyone for listening to this AOT podcast.
Thank you very much for inviting me.
Thank you for listening, and we hope you enjoyed this episode of the AOT Pod. Be sure to check out our other topics and give us a like and subscribe to get notified when new episodes become available. For more educational resources, visit the AOT website, aotent.org, and our YouTube channel. And make sure you attend our national conference where there are prizes for oral and poster presentations up for grabs. See you next time.